Hello, my name is Ravi Vij. I'm from My Cancer Haven, and we are here today with Dr. Nirav Shah, who's at the Medical College of Wisconsin in Milwaukee. And we're going to talk about CAR T cells for chronic lymphocytic leukemia. Nirav, welcome.
Great. Thank you for the invitation and excited to be here with you today.
So the thing is that obviously CAR T cells are now a reality for patients with CLL after a long wait, and you have been key in some of the trials that have been done in this area. So can you tell us about the Transcend study, which you have presented and have been an author on, and how these patients were accrued to this trial?
Absolutely. Yeah. You bring up a good point. CAR T was actually initially studied in CLL, yet it became one of the later malignancies to actually get approval. And it goes to show how hard it is to take a concept, an idea, and get it from, initial clinical trials all the way to FDA approval. So the Transcend study was that pivotal registrational study using a specific CD19 CAR T cell product called lysocell maraleucel for patients with relapsed refractory CLL. And so, for those who aren't familiar with CAR T, this is a sort of gene-edited T cell modified to redirect it against a specific protein on B cells, in this case CD19. This clinical trial took patients who had failed 2 or more prior lines of therapy, allowed bridging therapy while the CAR T cells were being manufactured, and gave a standard fludarabine cyclophosphamide lymphodepletion followed by the CAR T cell infusion. The primary sort of efficacy analysis was focused on those patients who were felt to have some of the more difficult CLL to treat. We call them double refractory. Those are CLL patients who have failed a class of drugs called BTK inhibitors and BCL2 inhibitors.
So, what was the demographic of the population enrolled?
Yeah, so pretty big study. You can see here the full study population was 118 patients, but that core subset was 71 patients, and that subset was looked at specifically to lead to an FDA approval. And otherwise, if you look at the data here, it's a very typical CLL patient population. The median age was 65 to 66 years. All of the patients had had prior BTK inhibitors. And again, in that venetoclax failed group, obviously 100% of them had failed venetoclax as well. And again, you're going to see some high-risk features such as high-risk cytogenetics in these patients. They're the ones who are more likely to fail some of our oral targeted drugs, which are very effective for the majority of patients with CLL.
So, what were the results of this study?
Yeah, so CLL uses a different criteria for response assessment, and so to get a complete remission in CLL is difficult by those criteria. But you can see here that in the core population, the BTK venetoclax failed. That 20% of patients achieved a complete remission. Now that may sound a little bit disappointing, but if you look at the undetectable MRD rate, MRD being minimal residual disease, that was actually much higher with about 64% of patients here achieving MRD negativity. And that can often be a surrogate of durable remissions. And so, yes, the absolute number of CR patients was low, but when you add in the MRD negativity, a lot of those patients actually achieved MRD negativity, but were still technically considered a partial response. As you can see here, the overall response rate was 42% in the full study population, or 48% in the full study population, and 44% in the subset population.
And how long lasting were these
Yeah.
responses?
So in a disease like CLL, right, this is a type of cancer that has a relapsing remitting course. And so the duration of response is really, really important. And what I can tell you here is that there were definitely a subset of patients who had really good, progression-free survival or duration of response. So the median time to next treatment in the whole population was 18 months. In the double refractory, it was 12 months. But again, there is a subset of patients that had very durable ongoing responses. And I myself, who enrolled quite a few patients on this study, have several patients who are now 2, 3, 4 years beyond treatment without needing a next line of treatment for their CLL. If you want to break it down sort of, by time point, you can see here 24 months, 42% of this double refractory patient population were still free from needing a next line of treatment. And so, does CAR T cell therapy effectively work for every single patient? Obviously, that answer is going to be no, but there's clearly a group of patients that have long-standing benefit, which is why this is such an exciting therapy to have available to our patients.
And I guess as far as subsets go, were
Yeah,
there
so there
anything?
was a couple of key findings. Those patients who had a better response, well, they did better, right? And I think we know that from a lot of different trials. So if you did achieve that complete remission, the median progression-free survival and median duration of response weren't even reached. And so obviously that was a small number of patients, but those who met those strict criteria did really, really well. For those who had a partial response, you can see here that the median duration of response and progression-free survival were obviously lower, but that's to be expected if they have some degree of residual disease, might be more likely to relapse. Survival at the end of the day is what matters the most, how long people live after they get a new treatment. And you can see here for both the patients in CR and for those patients who are in a PR that the median survival was not reached. And so people are actually living after getting this therapy, and that is an important finding of this.
And what about the side effects?
Yeah, so I think whenever you get a CAR T cell therapy, we have such a better understanding of the toxicities. When we think of side effects, we think of things like inflammation, the medical term being cytokine release syndrome, confusion or neurotoxicity, and you're going to see that here. And when we also think about toxicity, we think about how serious are the toxicities. And so, I want to really focus on the grade 3 or higher toxicities. Those are the ones that can be actually life-threatening to patients. And so, for the most part, patients tolerated the therapy well. The grade 3 or higher cytokine release was only occurring in about 8% of patients. Low blood counts are to be expected because you get chemotherapy and an immune modulating drug like CAR T, which are the majority of the high grade toxicities. I will make a note that there was 9% of patients that had grade 3 or higher neurotoxicity. And that's just something to understand that not every single CLL patient may be a candidate for this, and that patients can get really ill after getting treatments like CAR T. And you can see here that some patients did die during the whole CAR T process, and the causes of deaths are listed here, but there were deaths in 5 patients, most commonly due to infection or inflammation.
And anything to say about the CRS and other treatment emergent toxicities that you have not already talked about?
Yeah, I mean, I think this sort of just sums it up in a little bit more detail and goes through some of the other special interests. Infections are always a big problem after CAR T. We're learning more and more that infection risk is probably long term, beyond even the first 28 days. People can have low immunoglobulin levels, because we get rid of the normal B cells. So a lot of patients, and actually CLL patients, are familiar with getting IVIG because many of them get it actually before CAR T because they also can have hypogammaglobulinemia, but this can actually get worsen after CAR T, and so patients often need things like IVIG. And so I think the main message is that this therapy should be given in a qualified center, one that has expertise in managing the toxicities of CAR T, but it's now an FDA-approved option for those patients who are double exposed, and I think it's really a great, an exciting time for patients to have another tool in the toolbox for relapsed refractory CLL.
So before we end, obviously you just said this is for double exposed patients, and in CLL, as in a lot of other areas of hematological
Oh.
malignancy, we made tremendous progress, and we have now got even pirtobrutinib and other new BTK inhibitors coming down the pike. Where do you see this being utilized in the clinic? Plus, CLL patients often are older and frailer. How relevant a treatment is it for the majority?
Yeah, so I mean, CLL patients come in all ages, so obviously there's a subset of patients that are in their late 70s, early 80s, and this may not be the right treatment for them. And we're lucky, like you said, there's other drugs that got approved for the double exposed, drugs like pirtobrutinib. There's a new class of drugs called BTK degraders that look very exciting. There's new BCL2 inhibitors. So I think that's very exciting, but there are still a group of patients in their 30s, 40s, and 50s and with CLL. And for those patients who quickly progress on, sort of these two oral targeted therapies, it's important to get to CAR T, I think, sooner rather than later, because we know that there's a subset of patients that can get durable remissions. And from other trials, like I said, some of the early trials were done actually in CLL. There's actually reports now that some patients have had remissions going on beyond 10 years after CAR T cell therapy. And so, what's the benefit of having different options? Is that we can choose the right option for the right patient in the right circumstance. And that's where it, comes down to seeing someone who's got expertise in CLL and cell therapy to help guide patients through this decision making.
Well, thank you very much for taking the time to educate the audience about this wonderful and effective new treatment that has now become available and will almost certainly help a lot of patients. So I think that from my perspective, obviously there will be more advances to come, and I hope that I can reach out to you for a future program in the future.
Well, thank you for the invitation, and I hope this was useful to our patients and physicians.
Thank you very much.